share some thoughts with you today on ocular oncology. Who were instrumental in my getting here, because one day before I did not have a visa, I found out. And they worked it out and got me here somehow, and I don't know how they did it, but they did. So I thank you very much from numerous countries, some of whom are from India, as you know, including Santash. I'm proud to give the Nataraja Pillai lecture, and the doctor in the front row taking pictures right now is the grandson of Dr. Pillai. And when I got this notice about his active career here, something else struck me that was interesting. March the 1st, 1900 was the birth date of my mother. So my mother and Dr. Pillai were born on the same day, obviously in different parts of the world. So I'd like to share with you today some thoughts about what's new and interesting in intraocular tumors. And obviously in 25 minutes we can't cover this. It would take many hours because there's a lot going on. But I'm going to share some quick thoughts about uveal melanoma, retinoblastomas, and prompt treatment has been very responsible for improved prognosis in colon cancer, breast cancer, and cutaneous melanoma, which is the cousin of ocular melanoma. It's been stated in the literature that in cutaneous melanoma, tumor thickness is the most important prognostic factor. Melanomas less than 0.76 millimeters show nearly 100% 10-year survival. The majority are flat melanomas, pigmented macules. Now, what ophthalmologist in this audience would treat a pigmented lesion less than a millimeter in thickness? We tend to observe almost all of those waiting for growth, don't we? If we look at other ocular tumors as well, there's been improved prognosis for retinoblastoma, orbital rhabdomyosarcoma, and eyelid sebaceous carcinoma. But these lesions are not observed. They're treated promptly once the diagnosis is suspected. With regard to uveal melanoma, there's no such improved survival over many years, in spite of the fact that we have better methods of diagnosis and treatment. Are we waiting too long in some cases? Well, there has been a trend toward earlier treatment based on our teachings and others in recent years, but we cannot and we should not treat all choroidal nevi. My goodness, they occur in 5 or 6% of the population. So what are those risk factors that we've identified that help select which ones to treat? And we came up with a mnemonic in one of our articles called Too Fine Small Ocular Melanoma, TSFOM. If the original tumor is just greater than 2 millimeters in thickness, has subretinal fluid, symptoms, orange pigment, and a margin within 3 millimeters of the disc, these are all factors that are predictive of growth. And our studies showed that if there's 3 of these risk factors present, then there's a greater than 50% chance that that lesion will grow and presumably evolve into a melanoma. We later did a study designed to identify the risk factors for metastasis of these small lesions.